So we'll start with just the basics of ultrasound image generation and understanding the basics of the physics and the artifacts behind it. Sorry, I think that's the reminder to come here. Then we'll go into vascular ultrasound, touch briefly on vascular access as well as DVT screening. Then talk about thoracic ultrasound. I'll hand it over to Ijaz to talk about abdominal imaging, and then we'll end with cardiac to give you the outline.
My God.
Okay, so just to get started here, so again, the overview, we'll start about talking about the basics. I'll talk about vascular and then go into thoracic imaging. Wow.
She's sending 5.
4.
Okay, so ultrasound is exactly that. These are very high frequency waves, sound waves, which are higher than the frequency which the human ear can really hear, which is why you don't hear them as you're putting the probe onto the patient. Important to remember, and I'll come back to this, as you decide which probe you're going to use to image, it's important to remember that the higher frequency probes will give you really good resolution, but don't penetrate really deeply. And so they're good for imaging superficial structures and good for imaging for real-time access in terms of vascular imaging. The lower frequency probes penetrate deeper, and so you can get visualization of deeper structures, but on the flip side, the resolution of the images that you get is not quite as good. And so it's important to balance the two as you decide which probe you want to pick up. The way that these ultrasound images are generated is that there's electricity which flows through the cord and to the probe. At the end of that are these piezoelectric crystals which then vibrate. Those vibrations will then produce sound waves, which are then transmitted to the tissue as you have the probe on the patient. Those waves, ultrasound waves, will then echo back and reflect back to the transducer itself. And then we'll talk a little bit about exactly how that's transmitted into an image, but that goes back through the cord and into the processor, is processed into an image that you then see on this ultrasound screen. And so if you consider this P here to be your ultrasound probe, and consider the width of this arrow to be the ultrasound waves that are flowing from the probe to the patient. Consider A, B, and C to be 3 different structures that are in the path. So if you were to consider this to be, for example, the chest wall, rib, and pleura. Based on the properties of each of those tissue surfaces, you'll get a different amount of the waves being reflected back versus transmitted through that surface interface. And so, for example, here, tissue A reflects back about half of the wavelength, half of the waves, while half of the waves are transmitted through. Because B reflects back less, more of that is transmitted through C, and so forth. Based on the time that it takes for these waves to return to the ultrasound probe, the image is then processed to reflect the depth of the tissue away from the probe. And then based on the brightness, or how much, based on the amplitude of the waves that are returned back, that is then translated into brightness. And so then you can get this sort of 3D, or actually 2D view of what the structures look like, both in terms of depth as well as differences in brightness to help you differentiate tissue planes. There is a phenomenon called scattering of waves. So some of this is dependent on the particular tissue type. And so the only ultrasound waves which are then transmitted into an image are those that actually reflect back and hit the probe. Based on the type of tissue, some of those ultrasound waves get scattered and never make it back to the probe. And so that can produce a difference in terms of the quality of the image, which I'll show you an example of in just a second. The second thing is that depending on the angle of the wave to the tissue, you will also get a difference in the amount of ultrasound waves that are brought back to the probe. And so this is similar to the thoracentesis that we were just doing earlier this morning. If you're having trouble sort of visualizing the pleura just by angling the probe differently so that you're perfectly perpendicular to the surface of the pleura, you can make that into a brighter white line so that you can see it more clearly. So it's important to play with the probe angle as you try to get your images. This is an example of scattering of the waves. And so this is an ultrasound image of the heart. So this, we'll talk more about this later this afternoon, but this would be the left ventricle here. This is the aorta going out this way. And you know that the endocardial surface is actually a continuous structure. The fact that there's not continuation of this bright white line is simply because there's scattering of waves. So you can see that here the ultrasound probe, which is up here, is hitting perpendicular to the surface of the endocardium, while here it's not, and so you get some scattering. And so while we know that the endocardium is a continuous line, it doesn't appear as so on the image, and it's important to recognize that that's an artifact and not a real abnormality. Similarly, based on the structure that you're imaging, you'll get different brightness, as we mentioned previously. And so fluid is typically very dark here and hypoechoic. So this is an example of pleural imaging. So this is consolidated lung tissue here with fluid. The bright white here is the diaphragm, and this is either the liver or the spleen, probably the liver, depending on what side you're looking at. And so fluid tends not to reflect back any of the ultrasound waves. It sort of goes through and on to the next structure. That's in opposition to things like muscle, which tend to be bright white, and solid organs like the liver or lung tend to be somewhere in between. An additional artifact which you should look for are both shadowing, and the opposite of that would be enhancement. So if you remember, if the ultrasound wave, so this is an example of a gallbladder here with two calcified stones here. And so remember that the fluid, so the fluid-filled gallbladder here is going to not reflect back any of the waves, therefore it's hypoechoic on the screen. And so then you have actually a greater proportion of the waves get past and to the gallstone here, right? The gallstone's properties, particularly because it's a calcified gallstone here, appears really bright white here. And because everything is reflected back to the probe, everything behind it is shadowed out. And so while it's dark here, that doesn't mean that there's actually any difference here in the liver between the left side of the screen and the middle of the screen. It's just that the waves are reflected back to you. This is similar to what we see in thoracic imaging when you see rib shadows. So the ribs will reflect everything back, and so you'll see shadow behind it. So it's important to recognize that as not being hypoechoic fluid, but really just the shadowing, so that you can differentiate the two. Conversely, when you have, that's the shadowing effect. Conversely, you can also get enhancement. So while we know that the lining of the gallbladder is probably not any different here on the superior part versus the inferior part of the screen here, you see that this area in the back is actually brighter and more enhanced. And again, that's because it's going through the fluid here, which is not reflecting anything back. And so that area is reflecting back more and looking brighter on the image. And so again, things that are anechoic would be things that are fluid-filled. So ascites, pleural fluid, blood appears dark and black on the screen. Things that are solid organs tend to be hypoechoic, and so these will appear gray in color. And that's in contrast with muscles, such as the diaphragm, which will create this bright white image. So in terms of image optimization, there are a few things that you can do to make your image look pretty, not only so that it looks nice, but also so that you can clearly identify what you're looking for. So one of the things to remember is that you can adjust the depth on your screen, and I'll show you examples of that. Other things to think about are gain and coupling, which I'll come to. Patient positioning is actually really important, and so if you have the ultrasound machine behind you as you have the patient in front of you, it's really hard to sort of look at the screen and also know what your anatomy is. So typically you'd want to position it so that the screen is in front of you and the patient is between you, so that you can both look at the patient as well as the screen at the same time. Positioning of the patient, particularly for cardiac echo, can be important, which is difficult sometimes in our ICU patients, but ideally if you have them in the left lateral decubitus position, that can help the heart to swing out from behind the sternum and create clearer images, because the sternum won't let you see the heart behind it. When you're trying to determine the optimal image depth, it's important to center the structures of interest in the center of your screen. So while this may actually be nice because it's nice and blown up looking at the vessel. Actually having it here may actually be better for you because you'll be able to, the best resolution of the screen is in the center of the screen. Therefore you may actually get better visualization of your needle tip, for example, in this. What I typically do is to start off with the deep field of view to sort of get a sense of where I am in anatomy, and then as you sort of zero in on what you're exactly looking for, you can then center the screen on that image. The gain is what determines how bright your image is, and so I'll show you a picture of where to adjust this, but this actually just helps you to adjust the brightness, which will help you to differentiate tissue planes. And so if you have too little gain, everything just appears really dark. If you have too much gain, everything just appears really bright white, and it's just really hard to differentiate as clearly where different tissues start and end. Acoustic coupling just means that there are certain interfaces in which ultrasound waves are not well transmitted. And so this is most important when you're looking at the difference between soft tissue and air. And so really the point of the slide is just to remind you to use lots and lots of ultrasound gel. It's actually really cheap in comparison with everything else we use. And so you shouldn't be shy with that because that's actually what will give you the clearest images. If you have air between your probe and the patient, you're going to just get a lot of artifact and you won't get clear images. Lastly, I'll talk about different modes of imaging on the ultrasound. So there's the classic B mode versus M mode. I meant to take this out here because I have some better examples. But B stands for brightness mode. This is the classic 2D image that we're used to seeing in real time. M mode stands for motion mode. This is what we use to map out structures over time. It can be useful for looking at things like pneumothorax or the IVC with respiratory variations. And so we'll show you examples of those as we go along. But just to introduce the concepts, this is an illustration of what you might see in 2D mode. So this is an image of the heart. This is the ultrasound probe here. And you would see in real time a pie-shaped image like this in 2D real-time motion. If you were to send M mode through a plane here, what that will do is to map all of those structures over time. And so here closest to the probe is the thoracic wall, which is translated here in the image over time. And then as you go through, you see here that there's the aortic valve and then the left atrium here. And so the depth of what you see along the line in the 2D image corresponds to the depth of what you see along the line in M mode image. And then what you do is actually just hold the probe in that same exact position and it will map all of those structures over time. And so this is a real image of what that would look like. And so this is, again, a 2D image of the heart. This is going through the LV, the left ventricle. And if you were to send the M mode image through this plane, what you would see is those same structures here mapped over time. And so up here, as you'll learn later, is the RV, so the right ventricle. This large hypoanechoic area is blood-filled left ventricle. And so those structures correspond here to the RV at the top of the screen, the LV at the bottom of the screen, and you can see that as the heart contracts and relaxes with systole and diastole, you can see that there's changes here over time, and this is how you can actually get a sense of what the ejection fraction is beyond just eyeballing it. Color flow can also be useful, particularly in identifying vein from artery. What's important to remember is that red is not always artery, blue is not always vein. It's important to take note of exactly this, this key, which is usually in the upper left-hand corner. You can actually flip this, so while the sort of classic saying is BART, so blue away, red is towards, so that sort of describes the flow. So blue represents flow away from the probe, red is flow towards the probe. You can actually fiddle with this, and if someone has fiddled with it enough, you can actually flip the key in the upper left-hand corner. So what this shows is that whatever color is at the top of the screen is going to be the color of things flowing towards the probe, which makes sense because this is towards the probe is up here, and away from the probe is going to be the color at the bottom of the screen. And so things that flow towards the probe will be red, things that flow away from the probe in this image would be blue, Importantly, things that are perpendicular to the flow, things that have flow that's perpendicular to the probe actually turn out black. So if you were looking over the IJ, for example, and if you were directly perpendicular to it, it wouldn't be blue or red. And depending on which way you angle the probe, based on what direction blood is flowing, you can actually switch the color of red or blue as well. So it's important to keep those things in mind as you try to interpret those images. This is just an example of the keyboard that we see on our ultrasounds. Both of our ultrasounds are M-turbos, which look like this. And just so that you know where to adjust things from, so this is the depth here, which is important. Interestingly, the up arrow makes things more shallow, and the down arrow makes things more deep. The buttons over here are for gain. So this button at the bottom is a sort of a knob that you can turn to either increase or decrease the overall gain of the screen. These other two you probably won't be using quite as often, but you can sort of selectively change the gain on either the top of the screen or the bottom of the screen, so near gain or far gain. If you ever sort of start messing around with these and get lost in your image, you can always push the escape button, which is the auto gain, which will go to sort of your presets. Your presets will be based on when you click on this exam button, you'll pop up with a series of options. So for example, if you pick up the vascular probe, you can optimize images for vascular imaging or nerve imaging. The cardiac probe can be optimized for either cardiac or abdominal and etc. So it's important to take a look at that if your image isn't looking quite as you think it should. You can use the calipers here to make measurements when you're looking at things like IVC variation, so that can be useful. And then importantly, if you want to save images, you can push the save button or clip for videos. This will be important for you guys to remember as you go forward, because I think we're probably going to start making a library of these images for you guys so that you can start sort of documenting your competency in these areas. This is how you change between modes. So 2D is your typical image that you're used to seeing. Color will show you the flows, and then M mode will be important to use for things like pneumothorax or IVC variation. I'm not going to talk too much about Doppler today because I think that's probably a little bit more advanced imaging and probably beyond the scope of a 3-hour review. These are the typical transducers that you may see. Our machines don't actually have this curved probe, but what I'll tell you is that the linear probe versus the curved and phased array probes, there's sort of this split between the high and low frequency probes. So, your linear probe is going to be your higher frequency. So remember, high frequency probes give you really good resolution, but don't penetrate deeply. And so it's good for vascular imaging, imaging of the nerves. Curved and phased array probes both have low frequency, so both penetrate deeply but don't give you good resolution. The main difference between the two is that the footprint here for the phased array is much smaller and allows you to get in between the ribs for cardiac imaging. But you can use the phased array probe for abdominal imaging. Just the curved doesn't translate well to cardiac imaging because of the footprint of the probe. The ultrasound waves in the linear probe are transmitted directly in parallel away from the probe, and so this is why you get this nice clean square image. That's in contrast to the curved and phased array probes, which will give you pie-shaped images because in order to get a larger field of view, the rays are sort of transmitted at an angle. What that tells you is that as you get farther away, your resolution gets even worse because the rays are more widely spread apart. This is an example of the images that you would get with each. The linear probe will give you your vascular structures, which I think probably most of us are pretty familiar with. So again, good resolution, but doesn't penetrate deeply. This typically only goes to about 6 or 7 centimeters. The curved and phased array probes, this is an example, I think, of abdominal imaging here. This is, I think, the spleen, but I can't exactly tell here. And then this is an example of the IVC here. So again, it penetrates really deeply, but doesn't give you really fantastic resolution of the images. This is about that, I think. This is also important to remember is to take note of what the orientation of the probe is. And so this little blue dot, which is usually in the upper left-hand corner, corresponds to the marking on the probe that you're holding. And so the standard is for most ultrasound to have that in the upper left-hand corner. So it's important to remember that so that you're oriented. If things are in the upper left-hand corner, your probe should also be oriented so that it's to your left. So anything on the left side of the screen is to your left and vice versa. The other sort of standard orientation is to have the probe marker up towards the patient's head, so that things on the left side of the screen are towards the patient's head and things on the right are towards their feet. Cardiac ultrasound, because the cardiologists like to be different, the standard is to have the dot in the upper right-hand corner, so you may have to sort of mess with this a little bit as you're imaging, depending on whether you're looking at the heart or the abdomen. I know that as part of the FAST exam, which is looking at the abdominal structures mostly, part of that also includes the heart, and so you may see flipped images. And so in order, because their orientation is towards the upper left-hand corner, and so they sort of go along and image the heart also with the upper left-hand corner. And so it's important to take note of that so you know how to orient yourself. As you hold the probe, it's important that you hold both the probe, but then also to stabilize yourself on the patient, because you can slide around really easily. And so, while this person has a really good grip on the probe here, they're not well stabilized against the patient. So this is actually not sort of the most optimal way to hold the probe. This is what's called the tripod position, where you have your thumb and first two fingers holding the probe, and then use your back two fingers to sort of anchor yourself. You can also sort of use the heel of your hand to anchor yourself on the patient, but this becomes really important as you're manipulating the probe for cardiac imaging and turning the probe so that you can be sure that you're in exactly the same place and well stabilized. And so then I'll go into an overview of vascular ultrasound at this point. And so this is from the ACCP guidelines on the recommendations for competency for ultrasound use as recommended for pulmonary and critical care fellows. And so I've just summarized here. There's a lot more detail that's involved in the statement. But in summary, the things that you should be able to do is to identify the relevant veins and arteries that you're looking for, both for vascular access as well as for DVT screening. You should, of course, be able to differentiate vein from artery, not only based on anatomy, but also confirm based on compressibility and respirophasic variations. You should know about normal anatomic variations. So not everybody's artery and vein are exactly positioned in the same way in everyone, and so you should be aware of that as you go forward. You should know how to identify vascular thrombosis, so this is part of your DVT screen. And then there are sometimes non-venous structures which surround the areas of interest that you should know how to look at, just so that you know what you're going after. And then, of course, you should know that if there is a visible clot there, you should be compressing on it because of the risk of potentially embolizing that clot. And so there are two main indications for vascular imaging. One is vascular access, which probably most of you guys are familiar with, but I'll go through some of the basics and the data. And then DVT screening, which may be a little bit newer for some folks. And so just as a reminder, it's really important that despite the fact that you have images on your ultrasound screen, it's actually really important to remember that you also have to orient yourself anatomically. So I can think of actually two cases in the past couple of weeks in which there were IJ lines placed overnight, and I think that the residents sort of lost sight of the fact that you should be at the top of the triangle made between the sternocleidomastoid heads and the clavicle, and ended up having two sort of supraclavicular IJ lines, one of which caused a pneumo. So it's just a reminder to me that, besides confirming your anatomy on the ultrasound, to also look at the patient and make sure that you know where you are in relation to the clavicle when you're doing the IJ. So as a reminder here, there's the two heads of the sternocleidomastoid and the clavicle, which make the triangle within which you should find the IJ. Here on the right side of the screen, you can see the IJ here, which lies lateral to the internal carotid artery. The subclavian vein can actually also be imaged with ultrasound for vascular access. I think that this is probably something we don't do quite as often, but I think that there's growing evidence that we should. And in fact, while the subclavian vein lies here under the clavicle, as it extends out towards the axilla, this becomes the axillary vein technically, just a continuation, and really the place of access when you're using the ultrasound to access the subclavian is technically the axillary vein. And I'll show you how to image that as well. Classically, as you know, the subclavian vein lies on top of the artery, which is why folks don't worry so often about hitting the artery instead of the vein, although it can still happen. Using ultrasound can help to prevent that. And then lastly, the femoral vein here lies medial to the artery. What's important to remember here also is to keep in mind where the inguinal ligament is. I have seen cases where we've had sort of retroperitoneal punctures, sort of going over the inguinal ligament through the belly and then to the vein, which is not ideal, of course. So just, again, be aware of where you are in the anatomy and be a couple centimeters away from the inguinal vein. What's important to remember also is that sometimes the artery can actually sort of, as sort of imaged here, can lie just lateral but also a little bit superior to the vein, and you can adjust the positioning of the patient, so frog-legging them, so externally rotating the hip can allow the artery and vein to come off of each other so that it's easier to access. This is an example of respiratory variation. So here you can see the internal carotid here on the right side of the screen and the IJ here on the left side of the screen. You see that there's respiratory variation, so remember that as you breathe, you create negative intrathoracic pressure that allows the blood to fall into the heart from the IJ, therefore causing collapse of the IJ. The opposite happens in positive pressure ventilation, right, in which you have positive pressure causing an increase in size of the IJ with each breath. Either way, you should have a variation in the size of the IJ unless the patient is particularly full. It may not be as visible. If they're particularly volume overloaded, it may not be visible until you get to the top of sort of where their CVP is, JVP. This is how you would test for compressibility. So this is an example at the popliteal vein. You can see here that there's an artery here pulsating round. The popliteal vein looks sort of ovoid in shape, which is classic for a vein versus an artery. Additionally, as you push down, you're able to compress it fully, which means that both sides of the wall should fully touch each other. That's important to remember because an acute clot may not actually be echogenic, but you may just see that there's not full compressibility of the vein. So you really want to see that both walls actually touch each other. This is looking at the same vein and long axis. So if you turn your probe 90 degrees, you can actually visualize the vein and long axis. And you would want to, again, confirm that there's compressibility. You can see that there's actually some degradation of the image quality here. You see here that in still image, it looks like there's that bright white of both vessel walls. As this person is compressing, which I guess was probably me, you can see that you lose that bright white, which means that actually instead of just confirming compressibility, you're actually sort of moving off of the vein. And so you should be able to see that bright white of both borders of the vessel in order to confirm that you're actually still on the vessel. Does that make sense? So I think most of us, and you guys can correct me if I'm wrong, but I think most of us when we access the vessels actually access it in short axis. Is that true? Rather than long axis? There are actually studies showing that long axis may potentially be better. So this was a study of about 40 ER students and residents, so novice trainers, trainees working on phantom blue models. So this is a vascular model in which you can practice getting vascular access. What they found was that in long axis it takes a little bit longer, although it's not statistically significant, and 2 seconds really is probably not even clinically significant. But they're actually better able to visualize the tip of the needle. And so while I think what I've seen folks do in short axis is to sort of place the probe over the vessels and then enter with the needle, but not move the probe at all. And so
don't see the needle in the lumen.
Exactly, and
which
so
is useless.
So I don't know if it's completely useless, but ideally you should see the tip of the needle all the way down. And so there are two ways to do that. Either you can put the probe down, put your needle in, and find the tip of your needle, and follow the probe down the patient along with the needle, or you can have it in the same exact place, but angle the needle as you go. And this will be easier to see as we do our practicals tomorrow. But ideally, you should know where the tip of your needle is, because I've seen folks bury the needle completely when you know that the vessel is only 1 or 2 centimeters below the surface of the skin, and they're buried to like the full 4 or 5 centimeters. You're like going for really high, like LP or something at that point. It's probably deeper than you need to be, and so it's important to keep in mind how far you're going. It's harder, I think, to access the vessels in long axis precisely because you have this sort of the width of the probe when you're in short axis in order to be off by a little bit as you access your vein. When you're in long axis, you have to be perfectly parallel to the direction of the probe here in order to know, in order to see it on your screen. But that also sort of improves your accuracy, because then you know you're going straight for the vessel and not somewhere else. And you can visualize the tip the whole way in. This is what the needle would look like in long axis as you're trying to access. Once you've accessed your vessel and you've put your guide wire in, what I would encourage all of you guys to do is, again, pick up your ultrasound probe and confirm that you're actually in the vessel that you thought you were accessing in the first place. So it is possible that you can go through and through the vein and into the artery. So this is why it's important to visualize the guide wire as it goes through before you dilate, so that you don't have to call your vascular surgery colleagues, because that's never fun. And so you can visualize it both in short axis and follow it down from the insertion point into the vessel. Once you get to the vessel, again, confirm that it's fully compressible and not the artery. You can also turn it into long axis, and so here you can see the guide wire going into the vessel. And again, you would want to confirm that this compresses before you go forward with dilation. I put this up here just to show you that there is evidence to use the ultrasound beyond sort of intuitively being better, because you can actually see what you're doing rather than just going by landmarks. This was the sort of landmark study of about 900 patients, which probably took forever to recruit, is my guess. But you can see that along the line there are better outcomes in the ultrasound group versus the landmark group on pretty much every outcome that they looked at. So it took shorter. I mean, saving 30 seconds of your time is probably not a big deal, but it was quicker, which then sort of goes along the lines of being more successful. You actually have less complications, so you're less likely to puncture the carotid here 1% of the time versus 10% of the time. Remember, it's okay to, if you happen to puncture the carotid, you just have to hold pressure, but dilating it is actually where the problem is, and that's where ultrasound can also be useful, so that you know that you're in the right vessel. And then importantly, hematomas and pneumothoraxes were virtually non-existent, as opposed to the landmark group, in which that was a pretty common complication. Interestingly, and I don't know how to explain this beyond the fact that there were less attempts, you actually have less chance of having bloodstream infections if you use ultrasound guidance versus if you do just landmark guidance as well. So it's important to think about. You can also use ultrasound-guided guidance for subclavian lines as well. So classically, I think what I was taught when I was first learning how to use ultrasound was that for the subclavian, it's just so easy that you probably don't need to use the ultrasound. So when you go back to the literature, though, there are 2 studies which I'll tell you about. So there was this study which was done in quote-unquote less experienced operators, so folks who had had less than 30 lines total experience. And they were supervised, of course, by folks who were qualified to supervise. But what they noted was that the patients who had the ultrasound guidance, there was a pretty significant difference in their success rate. So by landmarks, only about 50% of the patients were of the operators were successful versus 90% using ultrasound. You can see again that the complication rate was very different. So 40% in the landmark versus 4%. those complications ranged pretty much from arterial puncture to hematomas. And interestingly, they use less insertion kits, so cost savings and probably a reflection of the number of times you had to try or start over. And so, again, the argument is that these subclavian lines are so easy, you may not need to use it, particularly if you're experienced and you know how to do these. And so this was a second study in which they studied, quote-unquote, more experienced operators. So these were all folks who had been doing lines for at least 6 years, and they randomized about 400 patients for this study. And again, you find that down the line, the success rate was 100% with ultrasound versus only 87% in the landmarks, so much better than what we saw in the novice group, but still statistically different and probably clinically significant difference as well. You're more likely to get it on the first try versus an average of 2 tries with landmarks, and then again down the line, much less likely to have these complications of hematoma, pneumothorax, hemothorax. So this is how you would image. And again, this will be easier to show as we do the practicals tomorrow. But you're actually, while you would sort of go more medially, if you were to go by landmarks, you actually go closer to the axilla. So you're here out closer to the axilla, just under the clavicle. So you're actually at the lateral third of the clavicle in order to image here. I think that the easiest way to do this is to start off by looking at it in short axis view. So remember the vein courses through the axilla and under the clavicle in this direction, so short axis would be oriented like this. What you see here is going to be the vein, which lies closer to the clavicle here versus the artery here. So if you actually run your finger along the clavicle along with the probe until you get to the lateral edge, you'll then start to see the vessels there. And typically the vein will run over the artery. You will actually also be able to compress it once you get out to the axillary vein. Once you find this, if you then rotate your probe 90 degrees in that exact position, and I think I found the best way to do this is to actually center your image on the vein, which is your focus, and then to rotate it slowly and all the while keeping that vein in the center of your image, then you're able to sort of most easily get into a longitudinal view. And this is what it would look like here. And again, you can actually see both the vein and the artery if you position this properly. Were you going to say something?
Yeah, and the other thing is to point out with this is that you can also often see the pleural reflection, and when you do that, and if you image in real time, it's also important to kind of keep an eye on where the pleural reflection is, so you avoid passing through with the needle and causing a pneumo.
Yeah, so
in fact, if you go back, there's the bright line that's labeled in that image. I think that isn't that the pleural line that they're trying to.
Here.
Yeah.
Yeah, actually, sorry, I think I'm oriented. I got disoriented.
Yeah.
This is another example, and I put this one up specifically for that as well, because you can see the pleural line. And again, you can measure the depth of where your pleural line is, so you should know that if you're going beyond that depth, you're running high risk of a pneumothorax. And again, this is particularly a line in which you would want to always know where the tip of your needle is. And so if you're able to get good enough at long axis access of the vein, this would be particularly a good one to try to do that, unless you're able to sort of follow the needle with short axis. But again, you should know both where the vessel is as well as where the pleura is. You can also look for lung sliding here, which we'll talk about, which rules out a pneumothorax, and so you should be looking for that both before and after you start the line. And so when it comes to femoral lines, there's actually not much in the way of sort of normal femoral lines, just as they've sort of classically studied IJs and subclavians. What I did find was this study, which I hadn't seen before, was looking at patients who came into the ER with PEA arrest, and so the question was whether we just sort of blindly put it in versus using ultrasound in the setting of a code. Is it better to use the ultrasound then? And I'm sure you guys have at some point or another been involved in code lines, and you know that they're hard because there's people at the top of the bed pounding on the patient's chest, and so things are moving all over the place, and it may be a little bit harder to access or maybe more likely to develop complications. And so this was a smaller study, about 20 patients who arrived to the ER in PEA arrest. There were 2 operators involved in this study, and all the patients in the study were got lines on both sides of femoral lines on both sides, and it was sort of randomized whether you started with the ultrasound or you started with landmark, but you got both. And the same operator did both legs, so that there was sort of trying to minimize the amount of operator variability. What they found was that that the ultrasound-guided line was more often successful. Additionally, you were able to get into the vein quicker and get the catheter in quicker. And additionally, and I think importantly, you were less likely to catheterize the artery versus a vein, which I think it's sort of hard to exactly know your landmarks and feel a pulse, particularly when the only pulsations are from CPR. So I think in this setting, ultrasound can actually also be useful. So it should usually be close by. You should probably grab it and bring it into the code as well. I don't know, is that sort of how the culture was in the ER programs where you trained, or I'm not sure.
We stopped putting in central lines and codes. We would just put in IOs.
Oh.
Yeah.
Yeah, so that's actually, yeah.
It's way faster.
Yeah. And so lastly, I'll talk about DVT screening here before I hand it over to Ijaz. And so it's important as you think about DVT screening to remember the anatomy, right? And so the places where clots like to form is where there's turbulent flow. That tends to be where there's branching of the veins. The 2 most important places which you should remember, so remember this is the iliac vein, which then becomes a common femoral. This will split off into the greater saphenous here, and the other branches, which I'll go over in a second. But really where the common femoral vein starts to branch off, as well as where the popliteal vein starts to branch off, are the 2 places where clots are most likely to form. And so when you order a vascular ultrasound, they sort of go through systematically every 2 centimeters all the way down the leg. It's probably a bit excessive for what we have the time to do, and probably more information than you necessarily need to know for the most part. But if you're able to identify where the common femoral vein branches and where the popliteal vein branches, then that 2-point exam is actually pretty accurate. And remember, you're checking for compressibility at these sites, so you're not looking for necessarily just echogenic structures within the vein, which can represent chronic clot and may be important to know about. But remember that acute clots are not going to be echogenic until they become organized and chronic, and so your only finding may just be loss of compressibility. So that's why you want to know that the vein doesn't just sort of kind of compress, but really that the walls touch each other. So this is an example of the common femoral vein. So this is where you might access the patient for vascular access. So here you have the common femoral vein here. This blue, there's a common femoral vein, and then the greater saphenous vein comes off here and then goes down the leg. This is what that looks like in ultrasound still image. I'll show you a video in just a minute. But here there's a common femoral artery. The vein lies medial to the artery, right? So we're looking here at the right leg. The saphenous vein sort of comes off medial and above. So this is on the right leg, this is on the left leg as it's branching in. Excuse me. Additionally, the common femoral vein will split off into the deep femoral vein and the superficial femoral vein, which is now actually just called femoral, because I think although it was traditionally called the superficial femoral vein, people did think of it as a deep vein, but in fact it is. And so if you see a report of a superficial femoral vein thrombus, it's actually considered a deep vein and needs to be anticoagulated. So that's why the nomenclature is sort of changing. But you'll see that the common femoral vein, which we saw up here as one single structure, as you move down the leg, will then start to split off here into the superficial and the deep femoral vein here. So this is sort of a trick question, but what is this here that we're looking at? So great, I was hoping you would say clot, but in fact it's not. And so actually what we're looking at here is actually lymph nodes. So it's important to recognize that what these sort of additional structures in the areas that you're looking at can be. So remember that the vein is going to be, so first of all, you can take a look in real time. You're able to move the probe around and follow the structure down and make sure that it's a continuous vessel rather than just one localized spot. The other thing that gives away the fact that this is a lymph node rather than a clot is the fact that this echogenic area is in the center of the round area that you're looking at. And surrounded by hypoechoic area, so that's sort of a classic finding for a lymph node. So keep that in mind in terms of your differential of what you're looking at, and just be sure to scan up and down as you go and look for these things. So this is a real-time image of what the femoral vein looks like. So this is actually starting lower down on the leg and moving up. I should have probably taken the video in the opposite way to make things easier, but if you look here, first of all, there's a couple of things I'll point out. So here's the femoral artery. The way you know this, again, is because this is a more circular structure as opposed to the vein, which is more ovoid in shape. Additionally, the walls of the artery are much thicker. And if you held this, there are some areas where you can see that there may be some pulsation. You may be able to see that better when you just hold the probe still as opposed to moving it up the leg. Additionally, you can see up here at the top of the screen, at the end of this image, is again a lymph node. So again, the circular structure with a anechoic area, and in the center of it is that dark area, which again is not blood clot but lymph node. And so here's the common femoral vein. If you see here, coming off medially, this is where the saphenous vein comes off. So do you guys all see that at the end of this image here? So this is common femoral vein with saphenous this way. The common femoral vein is going to split into, remember, the deep, which is down below here. So this is deep here, along with superficial here. And so those are sort of the main branch points which you should keep in mind that you're looking for. So where the greater saphenous vein comes off medially, where the common vein splits off into the superficial and deep vein. If you were to follow the artery down where the artery splits off, you may actually see what's called the lateral perforator. So again, similar to this going off medially, you may see a small vessel going off laterally. Those are the main branches at the common femoral vein which you should look for. And at each of those branch points are probably good places to recheck for compressibility because, again, branch points are where clots like to form. The popliteal vein can be imaged directly in the popliteal fossa. So while this is probably not something most of us are used to doing, it's actually quite easy to find if you stick the probe into the popliteal fossa. Positioning can sometimes be challenging in the patient in the ICU. So having the patient on their side will sometimes allow you to expose that area. There have been times where that's been pretty much impossible to do with me against a 400-pound person, in which case you can try to lift up the leg and have it flex so that you can look under into the popliteal fossa. If you have the luxury of having someone who can help you position themselves, having them sitting at the edge of the bed or actually even better lying prone can allow you to visualize that space better. This is again what the popliteal vein will look like. It's just like any other neurovascular bundle in which you have nerve, which is here, artery and vein sort of running together. If you follow the popliteal vein down, that will actually trifurcate. And so again, you want to try to find those branch points to exclude clots. This is an, I'm sorry about the subliminal message there, but so this is an example of the brachial vein with an echogenic clot here. So probably should not have been compressing on here because you would run the risk of embolizing it. But in any case, you can see that as this person tries to compress, you're not able to fully touch both the top to the bottom wall here. In addition, you see that there's echogenicity here, so this tells you that this is probably a chronic clot. Remember that if this was acute, you wouldn't see the echogenicity, you would just see that it doesn't fully compress. And so some of the data, just briefly, for DVT screening, this is an example of, there are a couple of studies out there now, but this is an example, again, pretty large for an ICU study, at least 130 patients who were suspected of having a DVT. This was exams that were done by a fellow, so ICU fellows, and they visualized the common femoral and the popliteal veins, and they compared that against a full venous ultrasound that was done by Vascular tech. What they found was that there was a prevalence of 20% of those patients who were suspected of having DVTs had DVTs in fact. The sensitivity of the ICU fellows exam was 86%, the specificity was 97%. So it's actually pretty decent in terms of what you're looking for. So if you're the fellow who's here at 10 p.m. at night admitting a new patient and you're concerned that the patient shock may be related to PE, in addition to cardiac imaging, looking for a clot can help you to sort of narrow out your differential a bit. Oops. And that will sort of lead into pleural ultrasound, which I'll try to touch on briefly as well. And so again, the statement on competence here tells you that you should be able to identify the structures that you're looking at, of course, right? That includes both the lung as well as the pleural space, but also the structures that surround it. So the chest wall structures, the diaphragm, things that are under the diaphragm so that you know what you're going after, particularly for procedures. When you look at the fluid, you should not only look to see that it's actually present, but also to determine the characteristics of that fluid, so whether there's some epigenicity in it, suggesting it may be complicated, or septations, again, suggesting that there might be complicated fluid spaces. You can also assess the fluid semi-quantitatively. I didn't include that here in the interest of time, but we went over it in the grand rounds that I gave a couple weeks ago. And then some of the specific findings which you should know include A lines, B lines, sliding lung, and lung point, which we'll go over. So the indications for pulmonary and pleural ultrasound include looking for pleural effusions, of course, to guide your thoracentesis and evaluation of those effusions. You can also use it to determine normal aeration versus edema or atelectasis, and then importantly for pneumothorax as well. So again, the way that the probe should be oriented, remember that the marker on your screen is going to be in the upper left-hand corner. That should correspond to the probe marker being to your left side as well, or towards the patient's head. Those are the two standard ways of imaging. So again, with the probe marker here in the upper left-hand corner, the patient's head is going to be on the left side of the screen, their feet to the right side of the screen. This again is lung effusion, the bright white is diaphragm, and liver below. So with normal lung imaging, you can actually get what are called reverberation artifacts. So these are in fact artifacts, but findings that you will see within normal lung. This is going to be a horizontal line which is parallel to the pleura. This is actually a normal finding. This is an example here. So again, the probe is up here, so this is the surface of the skin. As you go through, there's chest wall, so there's intercostal muscles here, and then this bright white line is the pleura. The reverberation artifacts mean that the ultrasound waves are bounced from the pleura back to the ultrasound, and then the artifact is that it then bounces back to the pleura and back to the ultrasound again. And so if you remember, the way that the image is generated is that the time it takes for the ultrasound probe to detect the waves coming back is translated into a depth, and therefore it thinks that there's actually another similar line equidistant away from where the pleura is. Does that make sense? And so you'll see these reverberation artifacts. So you have pleura here, this A line here. If you were to go deeper, you may actually see more of those as well. This is another example of that. So again, to orient you, these are the ribs. Remember, with highly reflective surface here of the bone with shadowing behind it. So you have rib shadows here. In between, you have the intercostal muscles. There's a pleura here with a little bit of fluid in between. And then as you go down, equidistance from the surface of the probe to the pleura, you can see that there's an A line here, and then this actually reverberates down to another A line here as well. So that's actually a normal finding. If you try to, oops, my lung sliding went away. If you were to image this, image the lung in real time, you'll see that the pleura actually slides along the chest wall. My slides might have just gotten mixed up here, but if you were to take M mode through the pleura here, so again, this is mapping all of the structures along this line over time. So again, the pleura is here halfway down the screen. That correlates to here, this bright white line, which is halfway down the screen. If you map those out over time, you get what's called the classic seashore sign in normal lung. And so remember, in a horizontal plane, even though your intercostal muscles move, they move along the same plane pretty much. And so as the M mode goes perpendicular through that plane, you won't get much in the way of movement in the vertical direction. Does that make sense? And so what you see plotted over time are just horizontal lines that go across your screen. That's in contrast to the lung, which has lots of sort of interstitial markings and whatnot that will move vertically in a vertical plane over time. And so you get this sort of hazy image, sort of looking like the TV snow almost is what I think it looks like. And this is called a classic seashore sign. So this looks supposedly like the water coming back off of the beach and leaving the sand behind it. This is another example of the seashore sign. So again, this is chest wall at the top, which are straight vertical lines going across, in comparison to the lung here, which creates this sort of hazy appearance at the base, bottom, which is called the seashore sign. When you have interstitial edema, you can develop what's called B-lines. So these are vertical lines that come down from the pleura and are produced as a result of interstitial edema. So they sort of look like searchlights that come down from the pleura. It's normal to have a couple of these per screen. If you have more than 3 or 4 per screen that you're looking at, that would be abnormal. This can reflect not only just interstitial edema, but other interstitial processes like interstitial lung disease. So things that would thicken the interstitial area would potentially cause B-lines. This is an example in a still image of what that would look like. So here's where the pleural line is, and you can see these searchlights coming down, which are the B-lines. Pleural effusion I won't spend too much time on because I think this is probably something you guys are mostly used to. But this is the lung here, effusion, and back here is the heart. It's important to always identify where the diaphragm is, and ideally, I think that this is actually easier to identify if you hold the probe with the probe marker up towards the patient's head, because then you can sort of run from the diaphragm and work your way up, and then have a clear sense of exactly how many rib spaces you have with fluid. Remember, you want at least 1 centimeter to 2 of fluid before you try to stick a needle in that space, and ideally you want to be a rib space or 2 above the diaphragm, so that as you try to put your needle here, it doesn't come in your view, so that you would risk puncturing intra-abdominal organs instead. If you were to run M mode through the lung, you would see what's called the sinusoid sign. And so as the fluid is sort of compressing and expanding with each respiration, you see that the atelectatic lung sort of waves in that fluid as well. So it creates this classic sinusoid sign. And then importantly, as you try to image, you also want to look to see that there's no evidence of any adhesions. So this is an example of where the lung is tacked up against the wall with fluid on either side. Additionally, you can see what's called hepatization of the lung. So this is consolidation of the lung. So this looks more, the consistency of the image here appears very similar to what you might see in the liver. Additionally, you can see these sort of really bright white dots through this, which are bronchioles as well. Again, this is another example of a loculated effusion. And then I went over this a couple weeks ago as well, but just as a reminder, ultrasound-guided thoracentesis does improve outcomes. You're less likely to have complications such as pneumothorax or hematoma, and you're much less likely to have a quote-unquote dry tap, which actually turns out most of the time to be under the diaphragm rather than above. And then lastly, we'll talk about pneumothorax before we take a break here. So classically, the places to look for a pneumothorax are going to be at the apex of the lung and at the top of the mid-axillary line as well. Remember that in our ICU patients, Many of our patients are usually semi-recumbent. They're very rarely fully in an upright position, and so the reason that we look for pneumos at the apex is because air rises to the top. And so when you're looking for a pneumo in a patient in the ICU, it's actually really important to start at the top, but then sort of work your way down, down the mid-clavicular line as well as the mid-axillary line, because if they're laying flat and air rises to the top, their pneumo may be more evident towards the middle of their chest rather than at the apex. Does that make sense? Additionally, if there are patients who are post-surgical, such as many of our lung transplant patients, they may actually develop loculated pneumothoraces. And so again, those are patients in which it would be important to go not only at a two-point exam, but sort of follow the mid-clavicular line and mid-axillary line all the way down to the diaphragm. Pneumothorax is defined by an absence of lung sliding, as well as an absence of the B line. So those were those rockets, the vertical lines, or searchlights that come down from the pleura. And when you put this into M mode, you would see stratosphere sign. And I'll go over what lung point is in a second as well. I'm going to see if this loads up for us. But I think this is, yes. So I put this up because it's actually a nice example of a side-by-side example of both sliding lung as well as pneumothorax next to each other. I don't know if this is projecting very well back there because of the light. Maybe we can turn it down. But this is an example of what sliding lung looks like. And so as you follow here, you can see that this bright white line here, which is the pleura, seems to slide along the chest wall. You can see that the intercostal muscles here move slightly with respiration, but it's at a different pace than the movement of the pleura here. One of the things that I found sort of useful to look for, because I found it really hard when I was first looking for these, is to look for these little black defects along the line of the pleura, which again are just scatter artifacts, but the fact that they move along the chest wall with respirations tells you that there is clear lung sliding. Additionally, you see that there's B lines that come down, so these searchlights that sort of go back and forth across, emanating from the pleura and across the screen. That's in contrast to here on the right side of the screen, where you can see that there is not really movement of these little defects in the pleura or these artifacts in the pleura. They sort of just move along at the same pace as the subcostal, intercostal muscles here. And so this is absence of lung sliding, which would be suggestive of a pneumothorax. It's important to remember that there are potential false positives. So remember, the absence of lung sliding just means that there's not lung moving in that area. So that's why it's important, particularly in some of our patients, for example, who have interstitial lung disease, in which you may have stiff lungs that maybe don't slide as clearly as normal lungs. It's important to look for lung sliding both before and after your lines or thoracentesis, so that you know that it was clearly there before. Because if it's not thereafter and it's a patient who, for example, had a lung transplant and might have adhesions or has interstitial lung disease and doesn't move so well, it may be hard to know what it looked like, whether that's a new finding related to pneumo versus something that may have pre-existed. And so things that can cause potential false positives, of course, if you have a right main stem intubation and you're looking at the left lung, which is clearly not ventilating, that could be a potential false positive. Other things, causes of bronchial occlusion, so if you had, for example, a left upper lobe mass that didn't allow the left upper lobe to aerate, you may see lack of lung sliding in those areas. ARDS, again, severe interstitial lung disease, pleural adhesions, and of course apnea, so if the patient's not breathing, you won't see sliding of the lung. If you have lung sliding, that's actually very highly predictive of a normal lung, but remember, it's in that area. And so if you have a small apical pneumothorax, but you're looking in the mid-chest, you may not catch it. And so that's where it's important to sort of scan across the whole lung field. And again, if you have absence of lung sliding, that's really sensitive, but not 100% specific, because there are other things that can cause it. The more specific finding is what's called the lung point. So this is a point where the lung is separating away from the chest wall. If you're able to visualize this point on ultrasound, that's very specific for finding a pneumothorax. And again, in order to look for this, you would actually follow from the clavicles down to the down to the diaphragm, or from the mid-axillary line near the armpit all the way down to the diaphragm. This was in a prospective study of patients who were thought to have pneumothorax. They were able to find that finding the lung point is not 100% sensitive, so it's sometimes hard to find, but if you find it, it's 100% specific. And I have examples here of the lung point. So this was a patient that we had in the ICU sometime last year, and you can see it's sort of subtle, but this right side of the screen doesn't actually slide. It's sort of just moving along with the intercostal muscles, while while the left side of the screen is sort of moving at a different pace here. You can see it sort of folding in on itself almost, the image. If you're to sort of compare side by side what it looks like in M mode, remember normal lung is going to have the Seashore Sign, so you get this grainy TV snow kind of image at the bottom of your screen. That's in contrast to pneumothorax, which just has these straight horizontal lines, because all you have is artifact from air, actually. And so you just get these straight horizontal lines going across. That's called the stratosphere sign, or the barcode sign. This is an example of what M mode looks like through that lung point. So remember, in real time, you see the lung sliding coming in and out of your view. If you send your M mode directly through that point, what you'll see is alternating air, so alternating stratosphere sign, alternating with the Seashore Sign here. So this is the lung coming in and out of view. So if you can find this, this is very specific for pneumothorax. This is another example of a patient. This is the same one that I showed you earlier. So you can see here clearly there's Seashore Sign here, followed by stratosphere sign, and alternating here. So very specific for pneumo. This is another example of the same finding. This was a patient that we took care of a couple of weeks ago. We did put in a chest tube in this patient up on 5 Tower. So here again, while here you can see sort of multiple cycles of breathing through the same screen, you can actually slow down how quickly it sort of images for you, or speed it up, and you can see that there were alternating signs here. It's not as crisp as I would like it, but you can see that there's barcode sign here with stratosphere sign here. This is again the same patient that we took care of a couple weeks ago, stratosphere sign, Seashore Sign. Okay, and then lastly, I'll just sort of impart you with the information that ultrasound is in fact actually better than chest X-ray at identifying pneumothoraces. So this is again a large study of about 100 patients or so. They found that actually compared to chest X-ray, ultrasound was actually able to identify many more of the pneumothoraces when you compare it to gold standard of CT scan. This is again another study which just supports the same findings, that the ultrasound is actually better than chest X-ray at identifying the pneumos. And so again, the summary of the things that you should take away in terms of thoracic imaging is not only to identify all the structures, but remember that lung slidings and A-lines are actually normal findings within normal lungs. You can sometimes have occasional B-lines, but if you have more than 3 or 4 per field, you should start thinking about more interstitial processes. And then be able to identify effusions or consolidation, which is again that hepatization of the lung, which we identified with the bright white spots being the bronchioles. And then pneumothorax, again, absence of lung sliding is quite sensitive. So if you have lung sliding, you can almost essentially rule out pneumothorax. If you have an absence of lung sliding, being able to find the lung point is a much more specific finding, and you can be much more confident that there's a pneumo present. So I think I'll stop there.